So we're here again to go through another, essentially, edition of what I'm calling Don't Believe the Hype. So remember that my aim here is to begin to build a case for some things so that you start to understand why I take some of the positions that I take and why I say some of the things I say to try to guide my approach, at least, to osteopathic practice. Now, what we're looking at here is just to take some time to discuss some of the stuff surrounding cranial osteopathy or osteopathy in the cranial field. One of the things that I find very interesting is that it is a model that was proposed by Dr. William Garner Sutherland, and he was a physician by training, an osteopathic physician by training. To my knowledge, he was not a trained scientist, a trained researcher, and all of his research, all of his experimentation was done in what could best be termed in vivo, right? So in living subjects. He was not doing any form of dissection that I'm aware of, although his initial inspiration was seeing, I believe it was a parietal bone. I may be mixing up my bones, but basically the inside of one of the bones, and it had the gills of a fish. Gills of a fish must mean respiration. That type of logic, that type of line of thinking would best be called rationalization or rationalism. I think it, therefore it is likely true, or I think it, therefore it must be true. The only thing I've seen with gills is a fish. Fish breathe through gills. It's breathing, right? So it's essentially low-level rationalization. Now, that doesn't mean it's correct, it doesn't mean it's incorrect, it just means that the level of evidence, that the manner in which it was put together is not as useful as it could be. Now, this isn't to discredit Dr. Sutherland. This is not to say that what he did was not useful. This is to say that what he did is probably not accurate in the way that many people would like to claim it is. Again, he wasn't a scientist. He wasn't a researcher. He did experiments on himself, apparently with baseball gloves. He would basically put them on his head and strap them down, and then he would see if they messed him up, more or less, to use fairly common terminology or fairly common vernacular. Other people took this, other people ran with it, other people came up with ideas. One of the central concepts is the motion of cerebrospinous fluid as well as pulsation. Cerebrospinous fluid is currently known to be a generally low pressure fluid. It is known to move. There is questions about what makes it move. There's questions about where it's created, where it starts, where it goes, its exact flow. This is not a fully decided matter. So to suggest that somebody coming up with an idea in the early 1900s, experimenting with it, and then putting out these ideas in the 1930s, and then having that evolve, and saying that that's the best way to do this, that's the best, most accurate thing, that's a bit of a problem based on information that we have now. Am I going to tell somebody, am I going to stand in front of somebody who is doing osteopathy in the cranial field and tell them they don't feel what they say they're feeling? No, I can't do that. I have no idea what you're feeling. You know what you're feeling. I don't. You also know that you might be lying to me. You also know that because you were taught and you like this methodology, that if you don't stick by saying you feel what you feel, then you lose credibility, so you may stick by your guns. Am I saying that everybody's doing this? No, not. But I am saying we have a problem with evidence here. So what I'm going to do is just show you some research that's relatively recent and talk about some ideas as to what may actually be going on inside the head as far as motion of cerebrospinous fluid, some of the things that may be driving it, in order to kind of build the case for what might be happening, and also to attempt to build the case for why the claims people are making is not likely what's happening, right? So we look at the first one here, the pulsating brain, a review of experimental and clinical studies of intracranial pulsatility. And this is from 2011. We're going to roll down to the part that I've highlighted, as I seem to be doing relatively regularly, and I went too far already. So this is in the abstract, right? The abstract is not indicative of everything that's in the paper, but it can provide a nice, succinct description and kind of piece of information that we can share, right? So what I have highlighted here, this flow is not steady. However, the systolic increase in blood pressure over the cardiac cycle causes regular variations in blood flow into and throughout the brain that are synchronous with the heartbeat. Because the brain is contained within the fixed skull, These pulsations in flow and pressure are in turn transferred into the brain tissue and all of the fluids contained therein, including cerebrospinal fluid. So essentially what you're saying, what's being said here is that as the arteries pulse, as blood pulses, as the heart beats and pushes blood through the arterial system, because you have a fairly fixed box in the brain, right, or in the skull and around the brain, what's essentially going to happen is inside of that box and inside of that tissue, that pulsation is going to diffuse through varying tissues, and that could be traveling across cerebrospinous fluid and then may have an impact on it, right? So we get this from 2011. If I remember correctly, the next one I want to look at is actually this way. This is from 2018. Flow of cerebrospinal fluid is driven by arterial pulsation and is reduced in hypertension. We're not as concerned about the hypertension portion. However, the hypertension portion, if you're studying something in essentially a pathological state, then it can give you insights. Knowing what happens when something goes wrong gives you insights into what it does normally, if that helps something make sense. Again, we go down. We're in the abstract here because the abstract is a succinct way to describe things that are found within the paper, and then sometimes what you actually get in the paper is longer and more convoluted. It doesn't communicate as clearly, so we just use it from here. CSF flow is pulsatile and driven primarily by the cardiac cycle. The speed of the arterial wall matches that of the CSF, suggesting arterial wall motion its principal driving mechanism via a process known as perivascular pumping. I will say that in this statement we want to be very careful. So it is making a statement that there seems to be enough evidence for that CSF flow is pulsatile. I think that's fair. Driven primarily by the cardiac cycle. I've seen some places where this isn't as fully agreed upon, but it's not completely unfair. It's at least possible. The speed of the arterial wall matches that of the CSF, suggesting, not proving, suggesting arterial wall motion is the principal driving mechanism via a process known as perivascular pumping. So essentially perivascular pumping is outside of the vascular wall. The pumping of the vasculature transmits that force out away from it, and that is very likely what's driving the CSF. They're saying that is a likely thing. It's not proving this, but they're saying that's very likely. So again, we want to be careful with the difference between something that says this is the cause and something says that this is a likely mechanism. And something that I hear a lot is, correlation does not equal causation. That can be true, but correlation can imply causation, and if you can be confident enough in the correlation, then it's as close as you're going to get to causation. So we need to understand the shades of gray even within that statement. We go over here to this next paper that I want to share to again build this case. This is from 2019, Cerebrospinal Fluid Dynamics and Intracranial Pressure Elevation in Neurological Diseases. Again, when you look at something in a pathological state and you can then compare it to its normal state, you can start to gain insight into how it normally works by looking at how it works when it's broken, right? So it's a way in to look at these things. And roll down to what I have highlighted. This one's further down. This is in the body of the paper. Did I lose it? Nope, there we go. So, CSF flow. From the primary site of secretion in the choroid plexus, CSF flows throughout the ventricular system of the brain. CSF flows from the lateral ventricles to the third ventricle via the foramen of Monroe. From here, it flows across the cerebral aqueduct of Sylvius to the fourth ventricle and onto the subarachnoid space through the apertures of Megendi and Luschka. This sounds like pretty standard fare for what most of us have been taught, especially in the osteopathic field and other anatomical fields or other hands-on therapeutic fields if they're looking at this region. It was previously assumed that CSF flow was driven by pulsations of the choroid plexus, so the choroid plexus itself, and now recent research correlates CSF flow through the system with both respiration rate and to a lesser degree heart rate. So this is one of the places where I say kind of that cardiac rate is not absolutely fully agreed on, so this statement shows some of that gray area. This correlation would observe the bidirectional flow of CSF, i.e. rostral movement during deep inhalation and caudal movement during deep exhalation. So what they're saying is that there has been observation that CSF fluid flow changes direction somewhat during different portions of respiration, so inhalation and exhalation. This is something that, as low-hanging fruit, a lot of people that like the cranial model would say, see, there you go, flexion and extension of the cranial mechanism, primary respiratory mechanism. But they just generally say that it's not, it's its own thing and it's somewhat independent of respiration. They don't often say that it is because of respiration. So there's a distinction to be drawn there. However, this correlation is challenged by multiple other hypotheses, such as CSF flow via the lymphatic system, in which CSF moves by convection, and some experiments have demonstrated CSF movement by diffusion. The reason I want to bring this one up is because there's a general overview of what is accepted as far as the primary direction of flow, and then they present what is going on at the moment, in that there is no consensus, there's no fully agreed upon concept as to what makes the CSF move. There are some ideas that have a reasonable amount of evidence. You can pick the one you like for now, but if you pick the one you like and say it's right, you're wrong. Because everybody knows it's actually studying CSF flow, not osteopathic practitioners alone in their office making up stories and saying, I read 2 papers and it's got to be this. The people who are deeply studying CSF flow don't agree. They know they don't agree. They're all studying their general hypotheses. One of the things that's important is that in science, in the scientific method, you are generally supposed to have a hypothesis. The hypothesis would make predictions as to what should happen if your hypothesis would be correct. You create an experiment in the hopes and the aims of falsifying your hypothesis. If you're trying to prove your hypothesis right, you're doing science wrong. If you do not, if through experimentation you fail to falsify your hypothesis, you have gotten information that allows you to be essentially more confident in your hypothesis. It doesn't tell you you're correct. It tells you you can be more confident in your hypothesis and that it accurately predicts things. Again, the aim of sharing this one is to show you there is not agreement between people who actively study, actively image, and actively engage with CSF flow. So it is very, very full of hubris that an osteopathic practitioner who is not studying this in a lab, doing this properly, to suggest that they know better than these scientists how CSF works. We take this problem that there are people within our profession who are sharing ideas, passing them along through students, essentially being procreators, right? You are the parent with your idea, you create your children through education, your children go on and propagate. These ideas are being propagated when there's information that you're not looking for or ignoring. I don't know that you're not looking for it, but I know that if you have seen it, you're ignoring that it exists. Maybe you're not looking for it, maybe you don't know it exists. If you do know it exists, you're ignoring it. That's not really appropriate. Don't go back to your pet theory when presented with evidence that should make you reconsider it. This evidence should make you reconsider it. The basic understanding of CSF is not the one that osteopathy presents, at least not in what I've seen and what I've been trained. The other problem that we have, and I've talked about this in generally speaking about accuracy of palpation. I don't know if you can hear that. That's hard. Living bone, the skull is fairly thick. A wet skull, like a wet bone, a living bone in the skull, is fairly thick. If CSF is believed to be low pressure, how are you going to get a sensation through this of a low pressure fluctuation at a slow rate? I don't understand how you're going to do that, especially when there's high pressure arterial pulsing known to be occurring in here, known to be diffusing through varying tissues. If you're going to feel something somehow, if you're going to feel an arterial pulse through a skull, I think you should call an emergency room. You should call 911. Depending on where you are, it might be a different phone number, but you should call the ambulance. That's a problem. That's not okay. If you can feel a pulse through the skull, either you're feeling a superficial pulse, but if it's inside, you should call emergency services. This is not something that you're feeling. You're not feeling CSF flow. I wish I could be nicer about this. It's not what you're feeling. The other thing is if you have somebody laying down on their back and they breathe, you should expect motion to be transmitted from the thoracic cage that is going to expand and contract and then transmit that motion through the vertebral column. You should expect to feel changes in tension at the base of the skull, where a lot of paravertebral musculature attaches. This is all blended into one. If I'm on my back and my head's on a pillow and there's space, and I take a breath, I'm going to move. That should transmit tension. If you're feeling tension somewhere between 10 and 14 times a minute, and you're calling that the cranial rhythmic impulse, if you're feeling it less than that, you're probably not feeling something that's an honest rhythm. You're probably lying about it, or you're probably making yourself believe that you're correct. I can't say that you're wrong, but you can't necessarily prove an experience to me without other evidence. Your evidence cannot be you reporting that you feel it. We need to be able to measure it another way for me to trust you. I'm not saying you're wrong. I'm saying I don't believe you. You can produce evidence to make me believe you, but the evidence that has been produced so far with respect to the cranial model, if you want to look at essentially a meta-analysis that was done with fairly strong methodology, you get this. This comes from 2010, Reliability of Diagnosis and Clinical Efficacy of Cranial Osteopathy, a systematic review. So we don't necessarily need to spend a ton of time on the methods. I will tell you that they are fairly solid. They follow a proper review process, a proper systematic review process, and what they come up with, okay? See if I can zoom in on this a little bit more so they can all be read, and that's about as good as I'm going to get. The conclusion: our results demonstrate consistently with those of previous reviews that methodologically strong evidence on the reliability of diagnostic procedures and the efficacy of techniques and therapeutic strategies in cranial osteopathy is almost non-existent. So if you're using an appropriate methodology based on research that is already in existence, that was done primarily by osteopathic practitioners, there's nothing. There's nothing that's of use. There's nothing that should be trusted. It's low quality evidence. It doesn't pass even the sniff test. Am I saying that this means cranial osteopathy is wrong? No. I'm saying that what cranial osteopathy says it's doing, it is not doing. We can prove that it is not doing what it says it's doing. Is it doing something good for a patient? Sure, probably. Is it doing what it says it's doing? No. Okay? It's important to start to understand and build your ability to at least read this research. If you're going to make a claim that you're doing something that's better than other people can do, you need to be able to prove it. Extraordinary claims are said to require extraordinary evidence. If you're going to tell me that you can palpate something that is physically unlikely based on the human nervous system and the sensory system, you have to prove that. If you're going to suggest to me that hands can differentiate things better or more sensitively than machines, you need to be able to prove that to me. We can test your hands. We can test the just noticeable difference of your hand's ability to palpate things by using haptic devices. We can do that. Your hands are not more sensitive than machines were able to build. The machines are purpose-built. Your hands are generally built. As humans, we live in a world where we interface with it through our general nervous system and our special senses. They are only as accurate as they are. In very general terms, they're not as accurate as we'd like to claim they would be. There is not enough evidence to honestly suggest that training makes you exceedingly more sensitive than anybody else to the point where you can feel a low pressure pulse through a hard skull. This is a problem if we continue to perpetuate this concept. Could we shift what we say about the cranial methodology, about osteopathy in the cranial world, in the cranial field? Is that possible? Could we shift the story we tell and still use the same methods and still get good results? Of course we could. The problem isn't necessarily the clinical interface that provides an improved subjective reality for the patient. The problem is the story we tell. So let's start to maybe talk about changing the story. Let's admit that the methods are maybe fine. Let's change the story. Stop believing the hype. Don't believe the hype.